Now we are moving to Professor Bax to Leiden. He will give, first of all, to thank him very much to attend this virtual Congress. It is a great pleasure to have Professor Bax with us. One more year, he has been present from the very beginning. He's a very good friend and colleague. We have worked together in both teaching and research in many aspects over the years, and a very dear and close friend of mine and of George Athanasopoulos, and we thank him very much for attending once more. His talk is one of his favorites, and this is about heart failure with preserved ejection fraction, and how left atrial function can contribute in the optimization of this assessment. We have spent all morning talking about heart failure and preserved ejection fraction. So it is coming with a good timing for wrapping up all this morning session. Jeroen and George.
Welcome, Jeroen.
Dear both of you, and dear all of you in the room, Kalimera.
Kalimera.
And thank you for having me. I'm gonna just put up my screen. Petros, I speak mostly about the ventricular, but how do we bring this all together, this sort of preserved ejection fraction? What does it mean? What is really the pathophysiology? Nobody really knows, but I think what we start to realize is that it is a disease that is related to a lot of abnormalities. So I'm going to take you through that in the next 20 minutes or so. And let me just get moving. So the more we do all these lectures, the more we start to talk, the slides become more simple, I would say. And I like that better instead of putting endless text and so on it. So I say heart failure and echocardiography. How do we assess systolic LV function? Well, that we do with ejection fraction. And everybody knows the ejection fraction value. And I think it is important to realize that it's a good parameter. It's a good parameter, but when you are in certain circumstances, it doesn't fit altogether. So when everything was simple, we did an ejection fraction. So many years ago, when the patients came to us as coming from, let's say, the general practitioner, and they were short of breath, the first thing we did, we saw them at the outpatient clinic. Second thing we did, we ordered an echocardiography, and we did laboratory tests. By then, we did not systematically test BNP. So we did an echo. We saw on the echo normal ejection fraction. So shortness of breath, not for us. Patient was sent to the pulmonologist. And now we realize that these patients actually do have something. They have a disease. If we talk about heart failure with reduced ejection fraction, it's so simple. We just measure the ejection fraction, and you see here two examples. One ischemic cardiomyopathy, one non-ischemic cardiomyopathy, and this is all we need to know, just the ejection fraction. If we don't see it very well, we just give some contrast. I'm sure you spoke about that today also in your Congress. We use it a lot. We use it in almost every patient to see the endocardial border contours. And with that, we can even more easily quantify the ejection fraction. What is actually an ejection fraction? We need to realize that an ejection fraction is nothing different than the volume that is in and the volume that goes out of the ventricle. This patient here has an ejection fraction, let's say 55%. So 55% of the blood leaves the left ventricle. There's one caveat with these things, because if I have a severe mitral regurgitation, then part of the blood is not leaving through the aorta, but part of the blood is going down in the atrium. And that means that if I have an ejection fraction of 55% with a severe mitral regurgitation, in the same patient, the ejection fraction, if he wouldn't have that mitral regurgitation, would be much more, would be maybe 70%. So it's important to realize that ejection fraction work well if everything leaves through the aorta. But as soon as you develop mitral regurgitation, the ejection fraction is overestimating what it really is. And what we really try to assess with that is the LV function. LV function. So our 2016 guidelines for diagnosis and treatment of acute chronic heart failure have this: heart failure with reduced ejection fraction, heart failure with intermediate range ejection fraction, 40 to 49%. These are the ones less than 40%. And this is this new entity where we used to say shortness of breath, ejection fraction normal, is for the pneumologist, is nothing cardiac. But we know better now. Symptoms and signs, ejection fraction equal or more than 50%, elevated levels of peptides, and at least one other criterion, which is relevant structural heart disease, LVH, or, as Petros mentioned, left atrial enlargement, and or diastolic dysfunction. Now comes introduction of Halfpath. So how do we assess that? How do we work with it? How do we implement it in the clinics? So echo and LV ejection fraction? No. So how do we assess LV function in those patients? And I put there when everything was no longer as simple as we used to have it. What do we measure in Halfpath? We need other parameters than LV systolic and probably diastolic function. We need something that reflects what's going on in the myocardium, because the common denominator of heart failure with preserved ejection fraction is that your left ventricle is too stiff. It cannot relax. And there's lots of different diseases that can come to that. So we got these new techniques, and I heard you speak about it already before in the previous talk. We got tissue Doppler imaging, which measures the velocity of the myocardium. And then we got strain and strain rate imaging, which is not looking at the velocities, but is looking at the active deformation. What's the difference between these two? This one can be passive. If you have a big infarct and still there is a velocity of the myocardium, it is passive motion. That has nothing to do with that the heart is actually doing some function. But this here, the myocardium needs to be alive to make that deformation. We can do strain imaging and we can do strain rate imaging. Strain rate is not so reproducible, but strain over the years has really become a very, very important player. Let me just pick up one thing. So I want to watch a little bit the time so that I know how long I'm speaking. If we talk about strain imaging, strain is taking part in three directions. It's the longitudinal, the up and down strain. It can be the inward strain, which is called the radial strain. And we can have the circumferential or the rotational strain. Actually, if you look at the heart, just the muscle, and you unwrap that, you see that it deforms in these three dimensions: longitudinal, radial, and rotational or circumferential. The one that we work with most is actually this longitudinal strain. And if you see here the left ventricle with all these different colors in it, yellow, blue, green, pink, other blue, red, these represent different areas of this ventricle. And in each of these areas, the strain is automatically measured. And you see here these different colors relating to these different segments. You see that? And the interesting thing is that this heart is completely synchronous because they all have the maximum strain at the same moment in the cardiac cycle. That means it's completely synchronized. What you see here, the dotted line, is the average strain of that ventricle, of all these segments. And here we see the peak strain. Now this global longitudinal strain, or the longitudinal strain I should say, is plotted like this, negative. But it could have also been plotted like positive, that it would have been here, probably. That doesn't matter. It's the number that counts when you look at it. How do we get to that global strain? Well, the software of both Philips and GE come to that in a different way, but the one from GE is the easiest to use like this. You have a 2-chamber, you have a 4-chamber, and you have a 3 or a 5-chamber. And these are acquired with the same probe, with the same heartbeat nowadays. And from that, the software can post-process for you, just like a nuclear scan, a polar plot, where this is the apex here, and these are the basal areas, and this is the septum, where the right ventricle inserts, anterior, lateral, posterior, inferior. This here, where I put the red square, is the global strain of this ventricle. It says -20. Forget about the minus. Just think about the number 20. 20 is, so to say, a normal heart. This I've been showing before also. So this is a normal heart with a global strain of -19, -20. This is an acute infarction in the inferior, posterior, lateral area, probably circumflex infarct. And you see that the strain here is completely gone. You see that very low numbers, 3, 5, 6. And here the strain is still preserved in this area. If I globalize that, this acute infarction comes around 14% in strain. This heart, the strain is completely gone. This is a patient with severe heart failure, and the global strain is around 7. If we're talking about systolic dysfunction, and you want to link the strains to that, this is a normal ejection fraction around 60%, 65%. This is an acute infarction with probably a remaining ejection fraction of 40%. And this strain, which is very low, that is a completely reduced ejection fraction, maybe 7, 8, or 9%. So that gives you an idea how these values relate to sort of ejection fraction in heart failure with reduced ejection fraction. Here you see that the global strains go really down and the ejection fraction goes down. What I told you, around 5, 6 is ejection fraction of 20%. This is 40% with about, let's say, a global strain of 13. And this is an ejection fraction of 60% where the strain is around 20. So what do we measure now in Halfpath then? We need another parameter than systolic and diastolic function. So I'm giving you a couple of examples, and for me, these work the best. That's why I've collected them and take you through it. This is a 21-year-old man using anthracycline for lymphatic leukemia. He has an ejection fraction of 60%. So systolic, everything seems to be fine. But you see that the global longitudinal strain is already affected in this area here. You see that there's -10 there. So there is something going on in that ventricle. And that something going on that all these heart failure patients with preserved ejection fraction have in common, that something going on is fibrosis formation in the left ventricle as a reaction, in this case, to chemotherapy. Here's another one. I'm going to just give you examples that everyone recognizes. Ejection fraction 66%. Very thick muscle. 2-chamber, extremely thick muscle. This is the strain map. These are the global longitudinal strains. And you see here 2 things. One is that sparing of the apex that everybody talks about. And all the rest basically is significantly reduced. So this global strain of this individual is 11%. So just forget about these minuses because it will confuse you. 11% does this patient have. Whereas systolic, everything looks perfect. Ejection fraction, 66%. This shows a lot of fibrosis or other depositions in the ventricle. Here is a hypertrophic cardiomyopathy. Ejection fraction, 65%. And you see this ventricle is huge. The ventricular walls are very thick. Papillary muscles even thickened here. Atria are enlarged because they constantly have to bring the blood to a ventricle that has a high pressures, probably. Look at the strain in this patient. GLS is 8. So if you look at this ejection fraction, 65, very thick muscle, that strain is 8%. Here is cardiac sarcoidosis. We don't see that much. See a little bit, some people talked about this indentation in the past. You don't see that much on your echo, but when you do an MRI, you pick up these lesions here, which is scar formation in cardiac sarcoidosis. Ejection fraction, 62%. Systolic, it's perfect. Diastolic, it's borderline, 17.7%. Diastolic, is that the right terminology, or should we just start talking about the continuity? This is the whole heart strain, as you see here. It's subnormal, 17% cardiac sarcoidosis. This is one that everyone recognizes. This is aortic stenosis. 83-year-old woman, severe aortic stenosis with an aortic valve area 0.9 centimeters square. Mean gradient is around 60. You see the thickened septum. It's very important to see that here. You see a valve that is thickened, calcified, doesn't open. We see here the Doppler. Ejection fraction of this patient, 62%. You see that the atrium is enlarged. That's typical with all these diseases, that the atrium has to work harder. The pressures are up to get the blood in the ventricle, needs to work harder. As a reaction with the increased pressures, atrium starts to dilate. If you would look at the atrial strain, you would see that it's significantly reduced in all these patients. Global longitudinal strain, 13%. And the main problem is here, where that very thickened septum is. You see that? That's where the strain is completely gone. And that builds the case that it reflects fibrosis or other depositions in the myocardium, or therefore the function is affected. So if we want to understand why strain is reduced, we should think like this. Abnormal function is a consequence of abnormal anatomy. And what is the abnormal anatomy? That's the structure. And normally there are myocytes, and in this case, fibrosis or other depositions in some diseases are taking over from the myocytes. Less myocytes being filled up with fibrosis, resulting in a stiff heart that cannot relax. And the atrium has to empty against a stiff ventricle, therefore is getting dilated. Lavi is going to increase, function is going to go down, but also the strain of the atrium is going to go significantly down. Anatomical imaging translating into functional imaging is what we're using. Let's talk about the anatomical imaging. This is the assessment of the myocardial fibrosis. I like this review. It shows here early fibrosis. It's called reactive interstitial fibrosis. Which patients do have that? Hypertension, valvular disorders, diabetes, genetics, and aging. Every heart has it to some extent. If we look at that situation, we see here blood vessels, microvascular arteries, and we see myocytes, and then we see in between we see fibrosis coming. All that blue here, that gray blue, is fibrosis. So it is a structural development, anatomical abnormality that's coming. If that lasts too long, then we're going to get a lot of fibrosis, as you see here. So much fibrosis that we can see it. This is becoming scar, macroscopic scar. This one here, if we make a picture, we don't see that on an MRI. But if we do an MRI on this one, you get that delayed enhancement. So replacement, scarring fibrosis, we have that in some inflammations, but we see it with acute and chronic ischemia or infarction. We see it in myocarditis, we see it in sarcoidosis. And you should start to think all of this like a continuum. This is the first stage, and this is the later stage, most of the time of the same diseases. I'm not going to talk about that here. That's a different story. So now let's look at this, what they call T1 mapping with MRI, because so far we spoke about functional assessment with echo. Now we're going to talk about anatomical assessment with MRI. This is the normal myocardium that we discussed before, completely normal. This is the diffuse reactive fibrosis, as we spoke about. You see? If this is if there is nothing, I see nothing on my late enhancement. There is no typical white scars. And if I measure this T1 times, which translates into extracellular volume, you see that the extracellular volume in the normal situation is 24%. So it's not true that it's full of myocytes and nothing else. No, there is some extracellular volume, 24%. If now the disease comes, the diffuse reactive fibrosis, which is a reaction again on some disease, then your ventricle and your atrium are developing this pattern. They get this diffuse reactive interstitial fibrosis. Can I see that on an MRI? No, I don't see anything, no delayed enhancement. What about my extracellular volume? You see, that's now 32%. If it gets worse, then you lose more and more and more of your cells, your myocytes. And we get big islands of scar. Now we don't call it fibrosis anymore. We call it scar. And then we see it on the delayed enhancement as this white area here. And my extracellular volume goes up further, which is now 36%. And the more scar I'm going to get, the higher this is going to be. Okay, what's the take-home message? The take-home message is that think in patterns. Think about anatomy, which is fibrosis. Think about functional consequences, which is the strain. Let's talk first about fibrosis. We've tried to do this on the atria. We cannot manage that. The resolution, the atrial wall is very thin. So to assess even delayed enhancement in an atrial wall is impossible. Parameters that we use is extracellular volume and late enhancement. The normal myocardium, native T1 is normal, extracellular volume is thus normal, and my LGE is not present. Now comes this reactive fibrosis in all the diseases that I showed you. My ejection fraction is still normal, but the native T1 is going up. Why? Because I'm losing myocytes and there comes fibrotic reactions. So my extracellular volume is going up, but there is still no late gadolinium enhancement. And these patients have a normal ejection fraction. But this is what it explains. Then we have the replacement fibrosis. Now this is a big scar. Native T1 is big, big, big time up. Extracellular volume is now much. And now you start to see the islands of delayed enhancement on your MRI. We cannot do MRIs on all these patients. Still, we have many, many coming. So we need something more simple, and that is our echocardiography. We can measure with tissue Doppler, but I told you that passive motion, etc., that's not good. We cannot discriminate between active reduced motion and passive reduced motion if you have an old infarct or so. But we can measure the global longitudinal strain nowadays, both with the Philips and the GE software packages. They give that all to you. And we have the ejection fraction. So if we now talk about functional assessment of the fibrosis, these are the parameters: global longitudinal strain and ejection fraction. In normal myocardium, I have a normal strain and I have a normal ejection fraction. In reactive fibrosis, my strain is going down but my ejection fraction is normal. All the cases that I showed you. The more this goes down, the more fibrosis is coming. If it gets a lot of fibrosis after acute myocardial infarction, but also in diseases that are there a long time, you see that then your ejection fraction is going down. It's a very simple talk if you look at it this way. Of course, there are lots of things that are not that simple, but in a way, if you think like this, you can understand and you know what you're measuring. We used to focus on heart failure with reduced ejection fraction. We measure an ejection fraction, but also can use strain. We didn't discuss much about this today. But the Halfpath situation is what we start to see more and more. That's why I gave you all these examples. We cannot measure ejection fraction because it's normal, but we measure left ventricular strain, and you start to see that going down. Now, what are the effects on the atrium? If a ventricle is stiff, the blood has a difficult time to get from the atrium actively and passively through the mitral valve into the ventricle. So that atrium starts to dilate because it's a low pressure part. And if the pressure has to go up to get in the ventricle, which is stiff, then it starts first to dilate. When it dilates, it's also reacting just like the ventricle with fibrosis. We cannot see it on an MRI because the resolution simply does not permit that. But we can measure it on strain. When you measure with your echo in the left atrium the strain, you can do that on the septal part, on the lateral part. You can also do it on the right side. And you will see that your strain is reduced. This is what I had to share with you. Thank you very much for having me. And I hope that the next time I can be with you again. Thank you very much.
Thank you very much, Jeroen. That was very nice and very, very practical, as often your talks are characterized with clear messages. Clearly, strain and deformation imaging has become part of our life, and I can see it here in Greece more and more being applied by many, many centers. But also in private practice by physicians, practitioners. The heart failure with preserved ejection fraction is obviously a challenge, a diagnostic challenge, imaging challenge by most methods. Do you think that the twist and untwisting mechanics of the heart may have added value? We haven't been talking a lot about the twist mechanics, and it may be the untwisting mechanics on a patient with heart failure and preserved ejection fraction may be a little step higher in more sensitive diagnosis of early stages of diastolic dysfunction or heart failure patients. Do you think that this has any mileage ahead, or it's a non-starter?
No, I think it's a good point. At some stage, I think in about 2010 or so, we worked with that. And we had the Philips equipment for that, and they could measure both the epicardial and the endocardial deformation. And based on that, we could measure the twist and the untwisting. And we saw absolutely what you're saying, that in certain diseases, this twist-untwist was absolutely affected. So yeah, we don't do that much with it because what we have now is very simple, and the twist-untwist is of course a little bit more complex, but the advantage could potentially be that you could look at endocardial damage and epicardial damage. So I think that is something that eventually I think we will get back to.
We have some questions from the audience, Jeroen.
Yeah, please do.
First, we have Sophia, who asked, which is the role of GLS in patients on atrial fibrillation?
In AFib, you can still measure the atrial strain, but you have to take multiple beats to get a good average. What you see if you measure that is that the global atrial strain is reduced. Does that answer the question?
Well, we don't have direct communication, as you know.
No, but I'm asking to you. I think that is what is being asked, right? So if you have AFib, either paroxysmal or chronic, then you have fibrosis formation in the atrium, and we have looked at that. Not comparison with MRI, because we cannot get that done because the resolution not allowing it. But what we see is if you compare atrial fibrillation, either paroxysmal or chronic, you see a gradual going down in strain. So if you have paroxysmal, you have less reduction in strain as compared to normals. And if you have chronic AF, then you see more reduction in strain. So it seems that more fibrosis is being formed. What we did in the past is that we also looked at the outcomes of those patients. And you see that if you develop a lot of fibrosis probably in the atrium, and you look at the ones where the function is really going down, that relates pretty well, actually, those two. Yeah. So I think, yes, you can measure it. It's hard to compare it with anatomy. There's this one group in the US with Dr. Marouche who looked at that, and they showed if, for example, if we start to talk about AFib ablation, and then your question is, do I have a lot of fibrosis in my atrium? And they showed that the more fibrosis they have, according to MRI, the more fibrosis they have, the worse the success is, or the least the success is when you do AFib ablation. So more fibrosis, lower strain, not good substrate for AFib ablation. Then they compared this strain, atrial strain, with and the fibrosis with the size of the atria. And in general, if you look at that, bigger atria have less strain, have more fibrosis. Smaller atria have more preserved strain, have very little fibrosis. But there are ones that have a dilated atrium, but still do not have any fibrosis. And therefore, the question that you can raise is, how do I select best my patients for AFib ablation? And if we could precisely measure the fibrosis amount in an atrium, then I think we could predict probably better who's going to respond. Because you have these patients that have a pretty large atrium, you still give them the benefit of the doubt, you ablate them, and they do very well. Then you have other patients who have a very small atrium, and you ablate once, twice, 3 times, and it comes back all the time. My feeling is that that relates to fibrosis. And the strain is probably a good marker to tell you, well, this strain is really reduced, and that strain is borderline reduced. So the first one I better not ablate, and the second one I could ablate. Your question is now going to be, do we have a cutoff who to ablate and not? I have no idea, absolutely no idea.
Well, that leads us to another question, Jeroen, by an electrophysiologist now. What about risk stratifying heart failure with mid-range ejection fraction and heart failure with reduced ejection fraction for sudden cardiac death, and whether or not there is a place for an EP-ECG and reduced approach, 24-hour related approach, such as a 24-hour Holter monitor or signal average ECG, for example, beyond imaging and genetics.
Yeah, absolutely. Very good point. Most of those things have not been tested so far, but we're starting to learn that these things probably interrelate well. So if you have a lot of scar in your ventricle, probably you're more prone to develop ventricular arrhythmias. So yes, these things need to be done. Of course, it's going to be very difficult because that's what people always want to see, like what is the cutoff? And I think we should forget about talking about cutoffs, because whatever cutoff in imaging we have used, it never works like that. You got ones that are exceeding the cutoff and they respond very well to the therapy. You have ones that seem pretty normal, way below the cutoff, and they don't respond at all to the therapy. You see what I'm saying? So I think it is a good additional parameter to give you an idea that, well, in this either ventricle or atrium, there is a lot of fibrosis. So be careful with your hopes for the future in terms of AFib, or if I have thinking about sudden death, we got to be more careful. but it will be hard to come with the cutoff value. If you look at every cutoff value in imaging that we have tried, it has always failed. Remember the desynchrony amount to get a CRT responding? It never really brought us. But we have learned that the bigger some parameter is, the lower the likelihood of the success. When the smaller the parameter is, the higher the likelihood of success. There is only one imaging parameter, so to say, that I know that is in the guidelines, and that's an ejection fraction of 30 to 35%, and that justifies for an ICD. But they never tested if that was the specific cutoff of 35%, right? They just took it as 35. That was the entrance criterion for the MADIT-1 and MADIT-2 studies. Otherwise, there was not that criterion. So if you say, do we have cutoff criteria in imaging? I say, no, not even that ejection fraction, because there's a lot of people with an ejection fraction much higher than 30% who get a sudden death. And there's also a lot of people that we give an ICD who never ever have any shock, although they had an ejection fraction less than 30%. So that is how I look upon these things. You see what I'm trying to say?
Jeroen, the hidden point of this question is that Professor Gatsoulis has written a very nice paper in European Heart Journal about sudden cardiac death in patients with preserved ejection fraction following myocardial infarction, and whether or not strain can better predict whose of those patients with preserved ejection fraction may lead to sudden cardiac death if we can better categorize this subpopulation of patients rather than Holter monitor or signal average ECG, or even indeed more invasive EP studies.
Well, I think all these things eventually are going to help because they all point in the same direction, a lot of fibrosis or less fibrosis. And to have more fibrosis is not a good thing. If you have it in the atria, you have a higher likelihood of developing atrial fibrillation. If you have it in the left ventricle, you have a higher likelihood of ventricular arrhythmias and thus probably sudden death. So I think what was proposed in the article is that we need some better markers than what we have at the moment, and the strain could indeed be something that can help. I'm just saying that I certainly believe that imaging has added value. The only thing is that people who work with it should not think if I meet the cutoff of 40 and I'm 45, then I cannot, and if I'm 35, then I can. You see what I'm trying to say? I hope I express myself clear, that I believe it gives you additional information, but also at the same time, people should not go by a specific cutoff, but rather use it integrated in your clinical decision making.
I guess you are coming to the COVID vaccination by age range. Can you let me push you? Just sorry, George. I just have a immediate following question up to that in relation to Professor Gatsoulis' question. These patients with preserved ejection fraction, do you think that mechanical dispersion may have an added role in defining these patients at higher risk for sudden cardiac death? It's becoming more and more popular now, mechanical dispersion, and I think this may have a real value, added value.
I agree with you on that as well. I think the mechanical dispersion, I think it was the group of Otto Smithett and Thor Edwardson and so who introduced that a lot into the clinics in studies. And for sure, we've also looked at those parameters, and certainly the ones with ICDs that shock very often, they have much more mechanical dispersion. And the mechanical dispersion also related with fibrosis and scar formation on the MRI. So yes, I'm fully with Dr. Gatsoulis that these markers probably all relate to fibrosis formation completely. So I think also, if then your next question is, should we use them? I say yes, because you increase your risk assessment of an individual. But if people come and they ask me, what's the cutoff? Should it be 3 or 4? Then I say I cannot answer that question, and I think nobody ever will be able to answer the question, but it asks for a different way of thinking. If you bring the imaging in and you see more markers going in the wrong direction, then probably you should be more aggressive with your therapies. Look at your patients. There are many that have an ejection fraction below 30%, never ever have an ICD shock.
George, can you wrap up?
Yes, it's a very interesting discussion, Jeroen. Thank you very much for the opportunity. I think that an interesting issue is in the borderline zone of strain between 16, 17, up to 20 in clinical practice. Do you think that in this scenario, is there a necessity to interrogate the dynamic performance of the strain? For example, we have patients with strain range between 16 and 18, being already in small doses of beta blockers, or, well, I think it's a scenario which is pretty often seen in clinical practice. How would you evaluate these numbers for strain?
Yeah, it's a good point. Actually, I think that what you're proposing is a good approach, probably. But all these things have not been tested in large populations. But if you look at your anecdotal patients, at our patients, we've been looking at those things. I confirm with what you say.
And also in this scenario, well, for the definition of Halfpath, according to the scoring, we need the LA volume to be above a specific limit. Quite often, we have scenario with marginal changes in the, 34, 35. Do you believe that in this scenario, the strain evaluation of the left atrium might contribute to the further clarification of this clinical scenario?
Absolutely, because if we look at a lot of these diseases, we speak about a polyparameter approach. So we bring in a lot of parameters and we take a look in which directions they go. I mean, if they're completely on the left, that's clear. They don't benefit. If they're completely on the right, that's also clear. They benefit. But the ones in the middle is where you need more information. And that's specifically where your imaging can push you to the left or push you to the right. And I am very much in favor of using this imaging in order to increase your understanding of a certain disease, which can help you move in the direction of certain therapies. Absolutely. Look, for example, something very simple. We have a lot of patients that with heart failure preserved ejection fraction that did not respond much to Entresto, whereas we had also a lot of patients that responded to Entresto. I'm not sure if that is all going back to the amount of fibrosis, but it might well be. And so I think that this better phenotyping of the target, which is the heart muscle, for which whatever therapy you're using, I think that that is important eventually for your decision to certain therapies, specifically if they become very expensive.
Okay.
Well, thank you very much, Jeroen. That was, again, excellent and triggered very interesting and challenging questions. So thank you, and goodbye from Athens, sunny Athens.
Thank you very much. I hope to see you next time again. Bye, Petros. Bye, George.
Let's see each other in physical scenario.
I hope so.
Bye.
Okay, bye. Now, ladies and αγαπητοί φίλοι και συνάδελφοι, έχουμε ένα διάλειμμα μέχρι τις 2:30 έχουμε διάλειμμα και θα ξαναξεκινήσουμε 2:30 ώρα ακριβώς. Όπως βλέπετε, για την ώρα έχουμε κρατήσει τα χρονοδιαγράμματα άξια και να ευχαριστήσουμε όλους τους ομιλητές και τους σχολιαστές για την αυστηρή τήρηση των χρόνων. Γιώργο.
Νομίζω ότι είμαστε ακριβώς 24 λεπτά. Είμαστε πολύ καλά για ένα μικρό διάλειμμα. Ραντεβού με την ομάδα εργασίας καρδιακής ανεπάρκειας.
2:30.